CNBC Fall Innovation Roundtable. We have a couple excellent presentations coming up today. My name is Sybil Hoyce, and I'm one of the leads for CACCN with a great group of people who also help out with presentations and a lot of the other work that we do here. I am joining from the traditional and unceded lands of the Swatmik people here just outside of Kamloops. But I know that we have lots of people from all across BC and all across the country joining us here today for this presentation. So I invite you all to reflect on the lands that you're joining us from today. And for our first presentation today, we have Melissa Guiyab and Dorinda Sinnott, and they're going to share a little bit about discharges with dignity. And I'm going to pass it over to them.
Oh, thanks for having us. Great. So apologies, everyone, for the technical difficulties. My name is Melissa Guiyab. I'm the clinical nurse specialist in the MedSurg ICU at St. Michael's Hospital in Toronto. And I'm a critical care and emergency nurse by background. First love is critical care, of course. I did emergency. I dabble in emergency nursing just to put myself out of my comfort zone, but been nursing for over 20 years now.
And I'm Dorinda. I'm a social worker by background. I work in the MedSurg ICU closely with Melissa. My role is I'm a care and transitions facilitator. So that's basically a discharge planner. I mostly deal with the patients that are leaving the ICU externally to other facilities or home.
And we'll be talking to you about our project of Discharges with Dignity.
Okay, so just quickly, disclosures and acknowledgements. We don't have any conflicts of interest to declare. We would like to thank the members of the MedSurg ICU Patient and Family Centered Care Committee, Jean-Paul Michael, Alyssa Ranieri, Celine Callender, and Donna Romano for their knowledge, expertise, and support on this initiative.
So from our talk today, we hope you come away with it with just being able to identify the needs of patients being discharged home or leaving against medical advice from the critical care setting. And we've decided to focus on patients who are experiencing homelessness as well as patients who use drugs. In our organization, we've actually got a lot of support for patients who have with mental health struggles, but these two patient populations were something that our staff were struggling with, so that's where we focused the bulk of our project. In addition, this presentation will review the principles of harm reduction, the principles of person-centered care, and we'll talk about how we were able to implement a patient-centered discharge process.
So just a little about St. Michael's Hospital and the MedSurg ICU. We are a part of Unity Health Toronto that consists of St. Michael's Hospital, St. Joseph's Hospital, and Providence, which is a rehab center. But St. Michael's is a 486-bed tertiary care teaching and research hospital in downtown Toronto. We have 27 beds in MedSurg ICU and approximately 1,500 admissions every year. So we provide specialized care that you can only get at St. Mike's. So we have patients from all over the province that come to us for services such as trauma care, stroke care, EVT, allergy desensitization, and apheresis. And increasingly, we've noticed a number of patients being discharged directly from the ICU or leaving against medical advice.
So just to go into a little bit more detail about where our patients go when they leave the MedSurg ICU, unsurprisingly, the bulk of our patients do transfer out to an inpatient ward, but we do have about 7% of our patients who actually go home, whether or not it's a planned discharge home or if they've decided to leave against medical advice. I know it's a small percentage, but it is a patient population that our staff struggled with. Because the process was inconsistent. So, and then at its worst, our staff were struggling with moral distress and personal discomfort when we have those patients that do want to leave against medical advice at 3 o'clock in the morning in the dead of winter. So that's how this project came about. So just to try to learn about how we could best serve our patients, we did a literature review, and I'll be going over some of the information that we found. With regard to patients experiencing homelessness and critical care, patients who are struggling with housing tend to be admitted to hospital more frequently compared to the general population. These people are also at increased risk of health issues and experiencing them at an earlier onset. And they experience disproportionately higher rates of infectious disease, mental illness, substance use, and traumatic injuries. There is some question about patients experiencing homelessness having longer hospital stays, increased mortality, increased acuity. There actually was a small study, retrospective cohort that took place in our site that looked at this patient population, and they did find that at least for our hospital, they were at higher risk of death. For those experiencing homelessness who survive their hospitalization, they're more than twice as likely to visit the emergency department again or be readmitted within 30 days. And this population is also 7 times more likely to leave against medical advice. For example, in a study by Nathanson et al., which was a retrospective cohort looking at ICU survivors, 8.3% of those patients without housing left against medical advice compared to 1.2 of those who were housed. Looking at what's in the literature with regard to discharge planning, some recommendations that came out of there were first and foremost, education for hospital staff on the needs of patients experiencing homelessness, a need to recognize the contributions of community supports. These community supports oftentimes go above and beyond what they are required to do to try to support these patients. There is also the issue of information sharing between hospitals and community partners, whether it's shelters, programs, or outreach services. In Ontario, personal health information sharing is guided by the Personal Health Information Protection Act, or PHIPA. And one key concept of that is the circle of care. There's a lot of confusion amongst healthcare professionals about who belongs in the circle of care, where, if a patient moves from community into hospital, does community still count as being in the circle of care and that sort of thing. So it's very important to build partnerships and bridges between community and hospital, because then that's where people are more likely to consider each other as being within that circle of care to share information that could benefit patients. Another key component was making sure that the patient themselves was involved with care planning, and that site-specific checklists could be useful for guiding discharge planning, because they, especially when it being site-specific, it takes into account the hyperlocal services. Looking into patients who use substances that come to, that are admitted to critical care, it's just important to know exactly what substance use entails. And that's the ingestion, injection, or inhalation of psychoactive substances that affect mental processes, which include mood and behavior. The DSM-5 criteria diagnosis for substance use disorder, alcohol use disorder, lists 11 criteria and then severities based on the number of criteria present. So the images that you see there, there's a mnemonic for the criteria, chew that cop, and then the spectrum of use just highlights from non-use, recreational to addiction. With regard to substance use and critical care, there's not that much literature for this patient population, unfortunately. Anywhere from 14 to 25% of patients in the ICU have substance use disorder, and these patients are at increased risk of greater illness severity, medical complications, increased mortality, similar to our patients who experience homelessness. And it's not unusual for, if you're looking at a Venn diagram, that patients may have both of these experiences. Anywhere from 6 to 30% of patients with substance use disorder leave against medical advice. Most common reasons for this are untreated withdrawal, pain, interactions with hospital staff. In addition, patients going through withdrawal, it'll impact their ability to participate with care, and that can cause issues and friction with the healthcare team. For those who survive their hospitalization, they are 12 times more likely to be readmitted within 30 days and double the risk of death. So when it comes to discharge planning for patients who use substances, a key component is that of harm reduction. So the definition of harm reduction is an evidence-based approach that refers to policies, programs, and practices that aim to reduce the adverse health, social, and economic consequences of the use of legal and illegal psychoactive drugs. But plain language, the ultimate goal is to reduce harms and save lives. There are 7 principles of harm reduction. Respect for human rights, pragmatism, which refers to the concept that people will choose to use substances, whether it's legal or illegal, and to accept that they use them for various reasons, whether it is just a personal choice related to trauma or mental health, or out of social inequities. And the goal is to explore drug use in a way that is not stigmatizing and accepts where patients are at. This ties into the concept of autonomy and supporting patients who use drugs to encourage them to be active participants in their care without coercion, discrimination, or like a trade, like I will treat you if you stop using type of scenario. Other principles include commitment to social justice, so just recognizing the inherent power imbalance within and between institutions. The priority of immediate goals, which is basically similar to the ultimate goal of just preventing death from overdose, minimizing the risk of spread of infectious diseases, working with peers and community networks, and commitment to evidence-informed practice.
So at Unity Health Toronto, we do employ a harm reduction approach. So that's basically meeting people where they're at. We want to work with people to identify their own goals in their journey towards improved health and reduce the negative impacts of any health behaviors, and using a trauma-informed, culturally safe, and person-centered approach. And then we also have concrete strategies we employ in the ICU that we'll discuss later. Just to talk a little about patient-centered care. So that is basically it's working with the patient and the family instead of just doing things to or for them. And the core concepts of patient-centered care are respect and dignity, information sharing with the patient, family, participation, that they're part of the team as well, and collaboration. So just a bit about person-centered language. Language really has the power to challenge or perpetuate stereotypes from individual interactions to policies and systems. The patients who have negative encounters with the healthcare system are less likely to seek care in the future. Person-centered language focuses on respecting and building up the strengths of an individual. Stigmatizing language can dehumanize a person and convey negative judgment towards the individual. People who use drugs may internalize stigma and believe the negative information they hear about themselves, which can result in harm and negative outcomes such as isolation, reduced self-esteem, shame, and not wanting to seek treatment and care. It can make people feel unwelcome or unsafe and become a barrier to individuals seeking care, support, and establishing relationships. So here we just have some examples of the more old-fashioned things that we used to, wording that we used to use, to what is the person-centered way to describe things now. So instead of drug abuser, addict, it's more putting the person in front. So the person who uses substances, the person who injects drugs. And then for people who are homeless, instead of saying a homeless person or a street person, it's a person experiencing homeless or a person without a home. It's important to encourage compassion and empathy and respect in order to foster an environment that's inclusive and safe for people to seek care. So this one is about capacity. So in Ontario, we, under the Healthcare Consent Act, a person is deemed capable if they understand the information that's relevant to making a decision concerning a treatment, admission, or personal assistance service, and they appreciate the reasonable possible consequences of a decision or a lack of a decision. So this is what we want to ensure, that there is capacity when someone is leaving against medical advice. advice. We do want to assume people are capable unless the healthcare provider has reasonable grounds to believe otherwise. And patient may, just to point out that patients may be incapable with respect to some treatments and capable with respect to some others. They can also be capable at one time and then incapable at another time to make those decisions. So at Unity Health, the healthcare professional proposing the treatment must first ensure that the patient has the capacity to consent to the treatment, and then ensure that the capable patient or SDM has provided the consent. So the goals of the Healthcare Consent Act are, they include promoting individual authority and autonomy, facilitating communication between healthcare providers and their patients, and determining the role of family members when the patient is unable to provide their own consent. Like I mentioned, the MRP would be called to determine their capacity if they want to leave AMA. So the next slide is we have a case scenario we wanted to talk about, so we can kind of put this. It's all well and good to talk about these things, but how do you actually use it? So you're the nurse on a night shift looking after James. He came in yesterday from a shelter with DKA and an altered level of consciousness. As his condition stabilizes, he's become increasingly awake, alert, and restless, pacing his room, talking to himself. And at 2 a.m, he tells you he has to leave right now before someone steals his belongings at the shelter. So what do you do next?
So 2 a.m. So as the nurse, I would just see where the patient was at in terms of ability to make decisions. So assess level of alertness, assess orientation. I'd also be just doing a behavior risk assessment. So in our unit, we use the violence assessment tool just to determine risk of violence. We'd be calling the physician. We're fortunate we have a resident and fellow that stays overnight, whether or not they're in the unit or they might be in the emergency department or elsewhere in the hospital assessing patients. But we would definitely get them into the unit to see the patient, and they would be the ones to determine if the patient ultimately determine if the patient is capable or not, but it would be in consultation with the nurse for their assessment. While waiting for that physician, we'd be employing some de-escalation strategies, such as we have iPads that we've downloaded a variety of apps on to see if we can distract that way. We also try to keep food in our nutrition station fridge. Offering food and drink is actually a great way to get patients to stay. Our internal medicine uses that strategy often to the point where they've actually had to reevaluate it because their patients have actually been gaining weight. Just sitting there, being an active listener, asking, why do you want to leave? What belongings do you have? And engaging in conversation. And then if based on risk assessment, if you are concerned about risk of violence, just having security on standby. So those are just some things that come to mind with this scenario. In our organization, we take staff safety very seriously. If there is a concern for violence from the patient, and the patient is an imminent flight risk, we are okay with letting them go. And then under Ontario's Mental Health Act, we would issue something called a Form 9, which is an order for return.
I don't know if you can hear me, because
Yeah.
I think the patient population that we see at St. Paul's is similar. And yeah, I think I totally agree. The moral distress around having a patient who's really sick, who could potentially be really sick again if they leave too soon, is really challenging. I really love how you describe the importance of assessing the patient and really assessing for violence as well, because those two things go hand in hand. I think in the effort that staff have to want to help, they sometimes will put themselves in risk to do so. And so reminding people and really embedding this violence assessment in the beginning of it is really important. That's what we're learning through our experiences at St. Paul's.
Yeah, we've had some really colorful experiences, and we have had staff, and we're trying to get the messaging, like, don't be a martyr. like it's okay. Your safety does come first. So with just this review of the literature, looking at what our obligations are, we worked on putting together a fairly standardized discharge process. So in addition to our literature review, we talked with our healthcare team, both in the med-surg ICU as well as other hospital services. And then we also took a look and did a review of what services exist in our immediate community.
So we created the following to support our ICU discharge process. So we do patient-specific care plans. We have some discharge checklists that we'll show you. We distribute care kits and harm reduction kits. And we also do some referrals to community support. So this is where we talk about the implementation. So interprofessional staff, we're familiar with care plans. That's not new. And the education that was started in fall 2023. That's shortly after I started in this role. It was a brand new role for the department. So we shared that in staff meetings, charge nurse meetings, because the charge nurses are the ones that are there 24/7. So they're really important to be initiative champions. We also do daily safety huddles during the week where we remind people about this stuff, and also new hire orientation, and for residents just to let them know that this is a resources available, and also just in time education when we hear someone that might be going quickly or even a planned discharge. We also do next winter accessory drive on the unit also to get some hats and gloves and stuff. So we have that ready to give people when the time comes.
So our patient-specific care plans were something we've been doing in our med-surg ICU for a long time. They are created with input from the patient and their family, the nurses, as well as other members of the healthcare team. And they're a very useful tool to help build a therapeutic relationship, establish trust, and ensure that care is consistent. As we go shift to shift, we have at least 150, I think, nurses that work in their unit from full-time to casual. So especially for our longer stay patients, it can sometimes be hard to make sure that the patient's needs are being met as they notice inconsistencies with care. And we've leveraged these care plans to include instructions for a safe discharge home as well. In addition, for patients that have mental health or substance use issues, we also add notes from any consulting services, whether it's inpatient psychiatry or addictions, as well as those from, we're very fortunate to have some advanced practice nurses that work in the hospital as well. We've got a trauma mental health CNS, as well as an inpatient consult psychiatry CNS that also provides some non-pharmacological strategies that help us connect with our patients and help with de-escalation. This is also a great place for us to put any hobbies or interests that our patients have, so that it can help keep them distracted, help encourage them to stay, to make sure that in addition to their physiological needs being met, that we're also able to meet their psychosocial mental needs as well.
So here is one of our checklists that we made. This one is for patients that are discharged directly home. And that's a planned discharge, not AMA. We'll talk about that later. So during business hours, they have me on the unit to help coordinate the care of those patients that are going directly home. But for the discharges on the evenings and the weekends, we do have these checklists available for the nursing staff, and with directions to flag these patients for me so I can follow up on them like the next day for any follow-up appointments or anything like that. And so the checklist, with these situations, when it's a planned discharge, we tend to have more time to make it a planned, thoughtful experience and set up services like home care if necessary. But as with patients leaving AMA, we've got to make sure all the lines are DC'd and ensure all the belongings are returned. I'm sure that is common everywhere, belongings being left behind, never to be seen again. We have a Rotary Center that we can access. It's attached to our emergency department. So that's helpful for patients whose clothes have been soiled or cut off when they first here, and we can also give them a care kit to take with them if they are underhoused. We help people go into shelter, help them call central intake to see if there is a shelter bed available, and give them a taxi kit so they can get there, and also ask if there's a community worker or a family member that they want us to call to let them know about the discharge. We can help people with that, and for people who use substances, we also can offer them harm reduction kits. We also escort the patient to the hospital entrance if they're unaccompanied. And if it's, as I mentioned before, just if it's after hours, we get people to let me know so I can follow up when I'm back. So this is our checklist for people that are leaving AMA. So we often, it's not all of a sudden out of the blue. People will start showing escalating behaviors when they're leaning towards self-discharge. So that's when we should be flagging the doctor so they can determine if the patient's capable to make the decision to leave, as well as doing a reassessment of the treatment. Like if they're on oxygen, can we titrate it down? If they're on IV antibiotics, can they be switched to PO? The team works together to employ de-escalation techniques and try to convince the patient to stay. And this is when the patient-specific care plan can be applied. So the checklist is written in order of priorities. If patient is ready to take off immediately, just the priority is make sure they're capable and DC any lines. So here's part 2 of our case scenario. So this, we've got the resident to come at 2 in the morning to come and assess James. He did determine him to be capable. So despite your best efforts to encourage James to stay until the morning, he wants to leave right now. So what do? So this is when you have our handy checklist. So we would run through all the steps on that, starting from the most important to do to the nice to do. Like I said, they make sure the lines are out and they're capable, make sure they have their belongings, try to make sure they have clothes. It's horrible to send someone out in a gown. We really want to avoid that if possible. We can offer them a care kit and any toiletries that were in the room that would just be thrown out, you can give them to the patient to take with, and any medications that are left behind. Make sure that see if there's anyone we can call for the person to give them a heads up that they're coming, we can I'll follow up with a call in the morning just to make sure everything went okay. We just encourage staff to make sure to remember to tell me when this happens. We can also try to escort the patient out who's leaving against medical advice to make sure that they're actually leaving the building once they are discharged. But like Melissa mentioned, if it is an unsafe situation and we can't get security there, just let them go. We don't want any staff getting hurt.
Just any before we go to the next slide, just any questions about like part 2 of our case scenario?
I was curious if you have ever tried to, and I'm sure maybe you have, but in general, do you recommend that people try and prolong the time for the patient to leave? Like, oh, let me just get something. Would you like something to eat? Would you like to try and like delay, hoping that maybe they change their mind, or maybe you get a chance to build trust with them and they decide to stay? Like, is that encouraged a little bit with staff?
Totally. Because no one really wants anyone to leave at 2 o'clock in the morning. So they do try those distraction techniques, or even just to be like, okay, we understand that you want to leave and we're not going to hold you, but at least stay till the morning, stay till it's a little bit warmer, till there's light outside. It's hard to get it, if housing is an issue. Oftentimes the shelter beds are full. Why don't we try again for a shelter bed in the morning, that sort of thing, just to at least, if they do want to go, try to not have it be at 2 o'clock in the morning or until the morning.
Yeah. And like offer them a warm blanket and just hang on until the morning kind of thing.
Yeah, exactly. I'll comment on the weather. I'll tell them, oh, it's so hot out there. It's so humid. It's horrible out there. At least we're air conditioned here, or there's a big snowstorm coming, like anything to try to dissuade them to make us look a little bit better than leaving.
Yeah. And then I guess just one other comment, because I know shelter beds, I don't know how it is, like we struggle with shelter beds in the dead of winter being full. So to leave at 2 a.m., there's usually where the shelters are at max capacity. We do try to, and we'll go into this in more detail, I guess, in our next slide, but we do try to offer a little bit of a Tim's gift card. So at least they've got somewhere somewhere warm to stay until they can try to get into a shelter. And so I guess on that note, we'll go to next slide.
Yeah, next slide. So this is a picture of what our care kits have in them. The majority of the toiletries come from existing unit stock. We just raid the supply room. Stuff like moisturizers, some tissues, sanitary pads. The winter accessories are donated by staff. Like Melissa mentioned, we might have a gift card. We don't tend to leave them in the kits, but during the day we can get them and give them to the nurse to hand out if needed. And we keep a stash of clothes on the unit just in case the rotary is not accessible if they can't get in the middle of the night because the person who has the access is busy doing something else. So here's what our harm reduction kits look like. There's the safer injection one and the safer smoking kit. So our hope is that by offering these kits, we're demonstrating to our patients that we're offering a safe, non-judgmental, safe space where abstinence from substances is not expected. The harm reduction kits are supplied by the Works, which is a harm reduction program run by Toronto Public Health. These kits are available also in a vending machine outside of our emergency department and on our mental health and addictions floor. So which was really cool to find out. You just press buttons like a vending machine, no money required though. While the use of sterile injection supplies is an effective means of reducing transmission of bloodborne pathogens, even sterile needles can be contaminated with skin or environmental flora during injection and cause local or systemic bacterial or fungal infections. Sterile supply distribution programs have been estimated to reduce the risks of sharing syringes and HIV transmission by 50%. The most common causes of infectious disease risk among people who inject drugs are related to sharing injection equipment, reusing equipment, and not using alcohol swabs adequately.
So another thing we can offer our patients are naloxone kits. So the first take-home naloxone program in Canada was actually out of Edmonton, which was back in 2005. And since then, there's been a lot of research into this intervention, and it's recognized by the World Health Organization for its potential for treating and preventing overdose due to its effectiveness in reducing deaths. It's not something that we stock in our unit. Our emergency department nurses do have a medical directive that allows them to dispense naloxone kits, but we unfortunately don't have the same directive in place, in part because we don't hand out the same volume as they do in the emergency departments. So oftentimes patients who use substances are followed by our addictions team, and our addictions team will offer them to the patients. Alternatively, we can pick up kits from our outpatient pharmacy or get our physicians to write a prescription for them. In addition to the supplies that we can offer, we also provide a bit of education for our patients who use substances around risk reduction strategies to prevent overdose. Common reasons for overdose include contaminated supply or loss of opioid tolerance while in hospital, so we caution against that. We, as part of our care kits, we do have a list of resources, which includes a list of local consumption sites, supervised consumption sites that we encourage our patients to go to use. These sites can also test substances to check for contaminants. We also caution our patients against mixing substances together and to use small amounts or test doses first.
So we also provide some community resources to the patients. We have a printout in each of the care kits. We develop partnerships with outpatient caseworkers and programs specialized in substance use, mental health issues, and housing supports. These connections help inform the care of the patient while they're in med-surg ICU and serve as a liaison to outpatient support. So I've listed a bunch of them there. I'll go into a few of them in more detail. The Navigator program, it's for patients who are experiencing homelessness, who've been admitted to the hospital hospital. So they have an opportunity to be followed by a homeless outreach coordinator after they're discharged to the community. It's really great. The counselor gets to know the person's situation while they're in the hospital and identify potential challenges that they're going to have in their recovery. And then after the patient's discharged, the counselor works with the patient and with their shelter and other community agencies to help the person access information, meds, supplies, and personal care. And they can also help them make and attend follow-up appointments for primary and specialist care. We also have a rapid access addiction service clinic that people can drop into. We learned about this really interesting project Dignify that we weren't aware of before. It's a case management program that provides older adults experiencing homelessness and mental health challenges the support to find and maintain housing, access Jerry site care, and improve their psychological and social well-being. And there's also a homeless outreach program and CACCN, another that's for people who have unmet complex healthcare needs, so they can have access to resources in the community. And other resources external to the hospital are Toronto Public Health. They do the works and TU supplies the kits. The City of Toronto, they coordinate shelter intake. There's a central intake number that you call. They in the winter they have warming centers. They organize the safe consumption sites, or some of them. There's also withdrawal management services. We actually have a few in various spots across the city affiliated with Unity Health Toronto, also community health centers.
So after coming up with this discharge process and talking about it with the staff, we took a look at the patients who were discharged home from the med-surg ICU between January and June of 2024. So that totaled 51 people. Of those 51, 31 of them were acute admissions. The other and the rest were from came in for desensitization. And then of those planned versus unplanned, meaning leaving against medical advice, we had 8 people leaving. And of those 8 people who left, 4 of them were experiencing homelessness. We had given 5 care kits out, 1 harm reduction kit, and 2 naloxone kits. That's not necessarily to say that we only had, two people struggling with substance use, but as part of being person-centered and meeting people where they were at, we would just offer the kits. Some people would decline or say that they don't have a problem, and that's okay. It's just, there for people if they want it, if they need it, and if not, we'll always continue to offer it.
Yeah, and we had some lovely feedback from one patient. He decided to leave against medical advice, and we gave him the care kit. And he actually said, "Oh, I can't believe you're not mad at me. This is really nice, and I really appreciate the parting gift for going." And that's why we do it. It was really nice to get that feedback. So we're just talking about sustainability. So to support this initiative, staff are regularly reminded of the availability of these resources during safety huddle, as well as in the moment when preparing the patients for discharge home or to leave AMA, because there's always new staff coming on, or people forget if they haven't dealt with one in a while. And we have these print resources such as the discharge check and care plans. So we keep them in the shared drive so everyone can access them 24/7. Although when we're there, we try to make sure that they're front and center with the nurse. And we also have the care kits are located in a central area of the unit so they can be accessed anytime.
So in conclusion, this low-cost, clinically responsive initiative supports the autonomy and dignity of patients and promotes a safe discharge process for both staff and patients. There are a few challenges with regard to sustainability, such as making sure we do have resources available, especially at nighttime, making sure that we're able to keep our comfort fund topped up so we can continue to offer things like those Tim's gift cards, and then staying up to date with programs and resources. There's a lot of pilot programs running right now, and just trying to stay on top of what's continued on to become a fully fledged program, or what pilot program was discontinued is always a bit of a challenge. We do recognize that this project is an ongoing iterative process, so we're always learning from our patients and our staff about what works, how we can make things better. We're always looking to partner with new services out in the community. We just learned about a new position in our hospital just the other day where there's a new outreach nurse that will help hopefully with coordinating all of those outpatient services that were listed on the previous slide. But ultimately, we hope that continuing with this initiative will help continue to increase staff awareness, build partnerships, and contribute to patient safety.
Thank you both very much. That was an excellent presentation. You guys have done such fantastic work, I think. And thank you for coming and sharing your work with us so we can learn from you.
Thanks for watching, everyone, and thank you for joining us on the BC chapter of the CACCN YouTube channel. We have a lot of great content from previous events we've had over the past 12 months. I would suggest subscribe and hit the notification button so you can know when the next thing is out. And if you ever want to come to our next event, we're on Facebook and on Instagram. Our links are listed below. And while I'm on the topic, if you're a critical care nurse anywhere in Canada, why don't you join CACCN? We have a ton of resources to help you be the best critical care nurse you can be. Go to caccn.ca and join us.